involved in quite a bit of MIS and percutaneous techniques, and I think there really was a void in the current options or ability for us to be able to deliver autogenous bone graft to some of these areas. And we got a couple cases that highlight the use of this device, which I think is really going to transform some of these procedures and gives us a great option to help in patients' care. And for all the benefits that Maxim had mentioned regarding percutaneous and MIS techniques, unless you've been living under a rock the past decade, these techniques are getting more and more popular. And we do see it as the future of a lot of our foot and ankle procedures. How can we take open procedures and accomplish them through a percutaneous and MIS type approach? So we have a couple examples of that to highlight for you today. So this first case example involves a patient of mine that had almost end-stage hallux rigidus. So they have arthritis of their great toe joint, and these are their pre-op weight-bearing x-rays. So on these x-rays, you can see some joint space narrowing, some osteophyte formation on the medial and lateral margins of the joint line. On the lateral view, you can also see the osteophyte formation on the dorsal head of the first metatarsal, as well as that proximal phalanx. And in these types of situations, we sometimes can offer patients joint sparing procedures, but I also talk to them about joint ablative procedures. And in this particular case, the patient did not want to try any joint salvage type procedures and was looking for more of kind of a one and done type procedure. And in my practice, that oftentimes is a arthrodesis or a fusion. I've been doing a lot of these great toe joint fusions percutaneously, especially as of late. And I think this is a great example of the use of the new device for that, the ArchiMIS. So here you can see us intraoperative, and how this procedure really works is by preparing the joint through a small percutaneous incision where we can insert a sterile Shannon burr. And this helps denude any remaining cartilage and also helps prepare the osseous surfaces for fusion. So we essentially use this burr in a percutaneous fashion, and we will also utilize fluoroscopy throughout the procedure until we feel like we've gotten a good joint prep on both sides of the joint. So oftentimes this involves expressing some of the debris from within the joint. Sometimes we will irrigate that debris out of the joint, like you see here, and then periodically checking under fluoroscopy until we get to a point where I call it the compression test, where we can actually compress the two sides of the bones together and eliminate the joint. Once I can do that, that tells me that I've prepared the joint enough that we can then insert our bone graft and place our fixation. This process probably takes about 20 minutes of preparing the joint and checking under fluoroscopy, both on an AP view and a lateral view, until we get to a point where we're comfortable with the joint preparation. Autogenous bone graft from the calcaneus for its use in the great toe joint. And the great toe joint is not a large joint, so typically a cc or 2 is going to suffice for this type of fusion. So we essentially harvest enough in the calcaneus to use in that great toe joint. Like Maxim had shown previously, here you can see our scrub tech loading the cartridge in preparation for deployment of that autograft. And it's a pretty simple process for that to happen. And for a great toe joint fusion, this is going to take somewhere between a cartridge or 2 to fill that space. Here you can see the introduction of the ArchiMIS cannula through the main portal that we also use to prepare the joint. You can also see we have placed guide wires for our screw fixation. And so those are placed but not crossed across the joint, but we have them in place and ready to go. And then we're going to deploy the autograft into the joint. And again, it's going to take about 2 cartridges to fill that joint space before we compress it together. So these are the fluoroscopy images showing that. And again, this took 2 cartridges, about a 1 cc volume of autogenous bone graft. So the image on the left, you can see before deploying the autograft. In the middle, that's deployment. And then on the right, this is with the full 1 cc volume in there. And now we're going to compress it together manually and drive our guide wires across the joint to place our fixation. Then there's our final fixation construct. We place two percutaneous compression screws in crossing fashion, and that compresses the joint and our autogenous graft that we just delivered nicely. And you're going to want to check it on multiple views, but that's kind of the final finished product, two cross screws and a nice compressed joint with a nice autograft in between there. This is what the incisions end up looking like. So if you've ever seen an open great toe joint fusion, typically it's done through about a 5 centimeter longitudinal incision, whereas here we have just one poke hole for the main working portal to prepare the joint, and then one poke hole for each screw that went across the joint. And then of course the small incision for the harvest of the autograft. So this is a big patient pleaser. The scars for these end up being very cosmetic in nature, but most importantly, we have not disrupted all the soft tissues. We have the full blood supply to the bone, the periosteum, the capsule. All of that is left intact, which typically translates to less postoperative pain, less postoperative swelling for that patient, and quicker healing, both for their soft tissues and for their bone, which means quicker return to recovery. And that's really the reason why we do these procedures through a percutaneous or MIS approach, is to really offer those patients those benefits.
Dr. Abicht, before moving to the second case, just a question for everyone on the line. Just pointing out your calcaneus closure incision. Can you walk people through how you do your closure for that?
Yeah, so most of the time I will use either gel foam or a synthetic filler just to backfill that site. You don't have to do that. We've actually done some studies that show that's not required to do, but a lot of times I will fill that just to give it some kind of matrix to regenerate bone and also to prevent a hematoma to that spot. Not that we're taking a lot of bone from that area, but typically I will backfill it. And then oftentimes I will just close it with some non-absorbable suture. In this case, it was a 4-0 non-absorbable nylon suture. If the incision gets big enough, I will sometimes add a subcuticular, like a Vicryl stitch underneath that area. But most of the time I would say it's just the nylon suture for closure.